including the ASO and MSO. In July 2025, Meg will serve as the Chief Behavioral Health Officer for the RAE and continue to support Rocky's role as the Behavioral Health Administrative Service Organization in Region 1. With her today is also Maureen Carney. Maureen is the Clinical Director of the Managed Service Organization, MSO, and Administrative Service Organization, ASO, soon to be the Behavioral Health Administrative Services Organization, or the BASO, at Rocky Mountain Health Plans. These programs are contracted through the Behavioral Health Administration to deliver substance use services, crisis services, and behavioral health programs for children, youth, and families in Region 1. As a licensed clinical social worker, Maureen has practiced in a variety of settings throughout the 15+ years of practice, including integrated primary care, early childhood and substance use prevention, and treatment. Meg and Maureen, the floor is yours. We'll turn it over.
Awesome. Hi everyone, can you hear me okay?
Yes.
Are we good? Awesome, great. Hi everyone, I'm sorry that I am not there in person today. There's a lot of work going on to prepare for the July 1st launch of both ACC 3.0, or the next phase of the Regional Accountable Entities for Medicaid, as well as the Behavioral Health Administrative Service Organizations, known as the BASOs, that both go live on July 1st, and there's a lot of work going into it now. I did want to let you know, for those of you that are interested, the BHA is having a community event. I know it's not Los Animas, but it is in Alamosa. It is on June 4th, and I can put the details in the chat later if there's people that are interested in attending that. So there's going to be a resource fair. So for providers, the BHA is looking for providers to have resource fair booths. And then there's going to be some Q&A with the Behavioral Health Administration. So just wanted to let you know that there's something coming close to you in 2 weeks if anyone's interested in joining that. So I'm Meg Taylor. I'm really happy to be with you today. I just wanted to talk to you about, give an overview for those of you who aren't super familiar with the Regional Accountable Entities or the BASOs, and what's coming in the next phase of the ACC and the RAIS, as well as what's coming in July for the BASOs. All right, next slide. A little bit about Rocky Mountain Health Plans. We are currently the RAI in Region 1 for the state, so that's the entire Western Slope and Larimer County. We are also currently the ASO and MSO under the Behavioral Health Administration for most of the Western Slope, for all the Western Slope, but not Larimer County for the Managed Service Organization, which most of you are most familiar with. In July 2025, we will be the RAI for Region 1, which will be 34 counties of the state, including Los Animas, as well as the BASO in those 34 counties, including Los Animas. Rocky Mountain Health Plans have been around since 1971. It was really a grassroots effort in Colorado to help people access healthcare that might have been underinsured, or more like the state and federal sponsored plans. Over the past 50 years, we have grown to include lines of business, including commercial, Medicare, and other state-sponsored and federally sponsored plans. We were acquired in 2017 by United Healthcare. You might see sometimes it says Rocky Mountain Health Plans, United Healthcare Company. We go by RMHP or Rocky. That's what you'll know us as a RAI or a BASO, but we are a United Healthcare Company. We focus on whole person health. It's one of the reasons why Rocky did on both the ASO contracts back in 2018 for crisis services, and have continued to work to be bid upon and awarded contracts that really round out this whole person space. We focus on behavioral health, physical health, and social determinants of health, or health-related social needs. Next slide. High-level overview of the programs and contracts that we hold at the state under the Department of Healthcare Policy and Financing. I mentioned we're a RAI. We also have Child Health Plan Plus. We have long-term service and support case management agency contracts, including the San Luis Valley currently. And then moving into ACC 3.0, as I mentioned, will be the RAE for Region 1. Currently under the Behavioral Health Administration, we are the managed service organization, so probably what you're most, again, familiar with and what this summit is about. That is substance use disorders only focus. We also have the Administrative Service Organization contract, which includes crisis services and programs and contracts related to children, youth, and behavioral health. Again, moving into the next fiscal year, starting in July, we will be the Behavioral Health Administrative Service Organization, or the PASO. Next slide. A little bit about the RAE, for those of you who aren't as familiar with it, there's 3 primary functions or components of the RAE. Primary care, so we work with a network of primary care providers. Behavioral health, the RAEs administer and manage the capitated behavioral health benefit with the state. So that ranges from everything from inpatient services for behavioral health to outpatient services and everything in between. So we manage the network of providers, payment and reimbursement, and including independent providers as well as comprehensive safety net providers and essential safety net providers. We also have a health neighborhood. This includes everything from schools to criminal justice to everyone that is part of the care and well-being of individuals that we serve across the RAE. Another primary component is care coordination, and we provide care coordination to all Medicaid members in our region. The state has prescriptive ways in the way we deliver care coordination. We stratify members based on quote risk level, and that determines the level of engagement, the primary level of engagement. Always person-centered if they need more or want less of our involvement in their care and connecting to care. All right, next slide. So I'm going to go over high level. I know that this might not be super relevant to everyone in the room today, but things that are changing in ACC 3.0 related to behavioral health. There is a new program called the Medicaid System of Care. It has recently changed to the Colorado System of Care, so I need to update this slide. So it was originally called the Child and Youth Behavioral Health Benefit, then the Medicaid System of Care. Now it will be the Colorado System of Care. You might hear COSOC out there. This program was developed after a settlement agreement with the state of Colorado. Department of Healthcare Policy and Financing had a suit against them related to kids languishing in residential facilities or other higher levels of care when they really didn't need to be there, need to be back in their home in the community, and were considered stuck. So this program is developed to help kids get back into their home and communities from those higher levels of care. It's a phased approach for this program over 4 to 6 years, and the population that is eligible for this program will increase. For the first year, starting in July, the primary population for the system of care are kids and youth, children and youth that are discharging from either qualified residential treatment or psychiatric residential treatment. So QRTPs or PRTFs residential and meet the age requirements for multi-systemic therapy or functional family therapy. Out of this system of care, as children and youth are discharging from these residential levels of care, they will receive both high fidelity wraparound and multi-systemic therapy or functional family therapy. So it's a lot of wraparounds, a lot of services that will be part of this phase 1 approach and for year 1. Another change, and I think this is probably relevant to some of you in the room, is peer services. In July of 2025, there are 2 peer service codes. So those of you who are familiar with this will know these codes. 80038 and 80023 are going to be limited to providers who are SUD clinics, so enrolled with Medicaid or HCPF as provider type 64, so SUD clinics, comprehensive safety net providers, and recovery support service organizations. So those two codes can only be billed and contracted with RAIs if under those provider types. Another change that's happening in ACC 3.0 is behavioral health secure transport. Currently, behavioral health secure transport is managed at the state on a fee-for-service level. This benefit will be moving under the capitated behavioral health benefit for the RAIs. So Rocky, as a RAI, will be managing this benefit. And this really is point-to-point access. So if someone has a crisis event, if someone is put on an MS hold, behavioral health secure transport helps get that person to the next safe place and level of care. So that's one more change coming. And then lastly, there's a change called a new benefits, integrated care benefit. Currently in the state, primary care providers can bill for up to 6 visits of very specific outpatient therapy codes. The state is changing that. That is sunsetting, and there will be new health and behavior codes that primary care providers can bill to the RAIs, or to the state, I'm sorry, for kind of like this hallway handoff. So if you're a primary care provider and you have an integrated behavioral health provider in your clinic, and you pull a behavioral health provider into a visit to say, hey, this person needs an assessment, the primary care provider can bill for a multitude of health and behavior codes. All right, next slide. To talk a little bit more about the SUD benefit under the RAIs and moving into ACC 3.0, there really isn't anything changing related to SUD benefits, but just to give an overview, under the benefit for Medicaid, there's inpatient withdrawal management, residential withdrawal management, partial hospitalization, intensive outpatient, and outpatient services. Some of the things that are not benefits under the RAI that Maureen will talk about under the BOSO and the current MSO are things like recovery housing and prevention. Those aren't covered Medicaid benefits, but really we can look to like the other side of the house for those kinds of services. Saying, you know, if someone with Medicaid as their health plan is in residential treatment and they need instead of going home, they really need more of like that recovery community and the recovery housing. We can work on the BOSO contract to get them connected to that care. Some of the RAI 1 specific programs that we have an internal contingency management program. We also contract with some providers for contingency management. We have found this to be wildly successful in working with people and helping them stay on their desired course of recovery or whatever that looks like. We also have specific substance use disorder care coordination under our RAI, including a peer care coordinator to help people along their journey. So it's not just they go in the door for residential and they walk out the other side and they're kind of left to their own recourse. We really try to wrap around and walk with the person along their journey. So we do have specific substance use disorder care coordinators. All right, next slide. Just for some things that I would love for everyone to be aware of and welcome you to join. We currently right now really and have for the past 7 years, really try to promote, hear the Medicaid member voice. We have a Western Slope Member Advisory Council. We have a Bridging Communications or Deaf and Hard of Hearing Member Advisory Council. We have a Spanish-speaking Member Advisory Council that is virtual, and so anybody is welcome to join that virtually, so you don't have to worry about traveling across 34 counties. We also have a Youth Voice Council, which we have found particularly helpful in bringing that youth voice to us and saying like, hey, this is what we need in the behavioral health space. We also have a regional Program Improvement Advisory Council. This is a requirement by the state of Colorado to bring stakeholders together to work with us and how we can improve how we do our work as a RAI. We will be continuing with member advisory councils. We will have one specific to Pueblo, and we'll also have a Southern member advisory council. Hoping that people from Los Angeles want to join it. It'll be kind of like San Luis Valley geography for in-person, but we always offer a virtual option for that. And one of the things that we have found particularly helpful and from our RAI members that work on our member advisory councils is that we have we regularly bring in providers and policymakers, so that there can be the dialogue between those that are setting policy for things that impact Medicaid members, as well as providers, so they can hear from members and also share what they do as providers to help educate members about what's out there as benefits and services. All right, next slide. Another thing that we will continue to do as a RAE is we have set course since the beginning of the RAE, and we'll continue to do is having community feedback events. Coming soon to your area, we'll be having some, and I'm happy to share that information with Shannon or Michael that can share it with the larger group. We will continue to have community as part of our governance structure. We have a community strategy committee that helps drive and inform the work that we do. We also will be continuing our Western Slope Native American Resource Center. This is something that we developed with representatives from the 2 tribes in Colorado, and really identifying the fact that, one, we need tribal representation to help connect people to services, if that's Medicaid enrollment, if that's driving them to appointments, and everything in between. So we do have Western Slope Native American Resource Center in Grand Junction, but they really span as far as wide as people need them to. We also have community integration agreements. These are agreements that we have with community-based organizations, providers, and others to help serve locally in communities. So those will be continuing. I'm happy to talk with anybody about that if you're interested. We have value-based contracting with behavioral health providers in our network. We'll be continuing that. This is really, creating space for providers to say, hey, I do this, I specialize in this, I specialize in this, and reimbursing them based on that value and service that they're bringing to Medicaid members. This doesn't necessarily really apply to Los Animas, but we do have what is called PRIME. It's a managed care organization contract that we have with the state of Colorado, where we do manage the physical health benefit in select counties on the western slope that the state has awarded us for. It currently does not apply to Los Animas, but we are always looking on it to expand that with permission from the state. One other thing I will say is that we are really focused on integration. Again, I mentioned that we have bid and been awarded these contracts under the Behavioral Health Administration because we believe in whole person care. These are not profit generating contracts. They really are so that we can say, this person has this going on this side. How can we, wrap around them on this side and bring and integrate the care and abilities that we have under these contracts that we hold with the Healthcare Policy and Financing, as well as the Behavioral Health Administration. We also, thank you. You're good. We can move forward. I mentioned for members, we'll have new member advisory councils. We'll have an additional regional program improvement advisory council. We have already outreached the surrounding areas and said, outside of Pueblo, and said, hey, do you want your own council? And we have heard yes, so we have that planned. It is coming. We are also going to continue to work with the youth voice and provide mentoring to members that want to join the council. This mentoring happens between current council members and those that are interested in joining. And next calendar in 2026, we will be having a Youth Voice Conference. We're working with Colorado Cross Disability Coalition for this conference. And we will be, more information to come about that, but we've really found that having the Youth Voice has very much helped inform the work that we do in the entire behavioral health space, but including the substance use disorder space. All right, go to the next slide. So for those of you who can see this is just a visual map of the new RAE regions. So this is again going live in July of 2025. We are, again, the entire western slope of Colorado, and then you drive east until you almost hit Kansas, but not quite. So we are at 34 counties. It's a lot of territory to cover, but we're excited to learn new communities and how we can give support in this space. All right, next slide. This is key contact information for those of you who are interested and not yet contracted with us as a RAE. Please reach out. The RAID Behavioral Health 5-Star Program, that's the value-based contracting that I was talking about. So if you want more information about that and, like how you become part of that program, for around value-based services and reimbursement based on the service delivery that you have. Please reach out on that. If you are a comprehensive safety net provider, we've connected with all of you, but there's contact information as well. And then, any escalation, please feel free to reach out to me. All right, next slide. All right, I'm going to turn this over to Maureen to talk about our current behavioral health administration programs, and then, what's new under the BOSOs. One of the things that I decided for this presentation is because we are still actively contracting with providers under the BOSO, I wanted to hold on providing the list, especially for geographically specific providers in your area, relevant to both SUD and other services under the BOSO. Again, I'm happy to share that with Shannon and Michael to share with the group. I felt it was a tiny bit premature because we have not finalized all those contracts, but so there's more to come, and hopefully everything will be signed, sealed, and delivered by 7/1. All right, Maureen, I'll turn it over to you.
Thanks, Meg. Hi, everyone. I'm Maureen Carney with Rocky. We thought we'd first kind of lay out the current landscape of the programs that we have contracts under the VHA with. Just to help kind of understand how the services are under the ASO and MSO, and then what they will look like starting July 1st as Behavioral Health Administrative Service Organization, or BOSOs. So currently we are the ASO for the Western Slope of Colorado. That includes crisis programs and programs for children, youth, and families. So under crisis, most common to all of you is probably mobile crisis response. So that's where an individual can call 988, be connected to Colorado Crisis, and get dispatched on-site crisis support as needed. That also includes under crisis services, crisis stabilization units, respite services, and one other that I'm blanking on right now. And then there's the Children, Youth, and Mental Health Treatment Act. These are folks who are non-child welfare involved, do not have Medicaid, and it's really a funding mechanism to help pay and maybe fill the gap where other commercial insurance or Medicaid cannot for mental health treatment for children and youth. And so we have a clinical care coordinator who will walk families through that process to see if they qualify for services under CYMHTA. And then we have the Family First Prevention Services Act. Those are referrals that we get from County Department of Human Services, Department of Youth Services, and the RAIs currently to assess children and youth to see if they are appropriate for residential treatment or if their mental health needs are best met in community-based services. And then we have the Colorado System of Care, COACT, also known as High Fidelity Wraparound, really intended to support youth at risk for out-of-home placement with wraparound services that support their family and the youth. It's very youth-directed and family-centered, an intensive kind of 12 to 18-month average program. And then last is our crisis resolution team. And that is really intended to support youth who are involved in crisis services at whatever level and need really more ongoing short-term interventions to help stabilize them and keep them sort of out of higher levels of care. So that's the crisis resolution team. Next slide, please. And then our managed service organization contract through the BHA supports people who need services along the continuum of care. So really looking at withdrawal management, residential treatment, MAP services, outpatient treatment, and many, many more. And then also along with that, Meg had mentioned recovery support services. So we fund providers who hold events within their recovery community organizations to have pro-social activities for people who need recovery support, peer services, recovery living communities, and then under recovery living communities, we also fund providers who can offer scholarship support. So as Meg mentioned, if someone is stepping down from treatment, they may need a few months rent in a recovery living community, and those funds can help support that. And then also we work really closely with child welfare departments to support individuals, family members, anyone living in the household who has child welfare involvement and a need for substance use treatment. And we help connect and pay for treatment for folks in child welfare. And then also we have a care coordinator that supports individuals on involuntary commitments. So those are people who are court ordered to treatment, and our care coordinator supports them from getting assessed, getting connected to providers, and getting services along the continuum for as long as they need it. And those are really up to 270 days, so really long-term kind of people with long-term treatment goals. I think the thing to think about with managed service organizations and the programs that we fund and how it will continue to be funded under the BOSO is think about the funding following the provider. So we fund providers directly. We don't fund individuals directly like Medicaid does, right? Medicaid follows the individual wherever they go. MSOs and BOSOs are really looking at funding providers and creating capacity within a network of providers to support people who need care. Next slide, please. And so many of the functions under the ASO, or all of the functions really under the ASO and MSO, will be part of the BHASOs or BOSOs. So those include everything that I described under the ASO, MSO, and then additionally, it will include mental health contracting. So currently, supports for safety net programs that the BHA funds directly will now come through BOSO. So we will contract with safety net providers to create capacity for people that need mental health care. And then one of the new components is going to be care coordination. So while we already offer care coordination in many of our ASO and MSO programs, this will be expanded to include anyone in the region that may need connection and support to services. Next slide, please. Priority population. So the BHA is really clear in their contract language about who should be prioritized in our network. And this is something that we communicate very clearly to our providers about who the priorities are. Of course, because these are payer-agnostic programs, they're open and available to anyone that needs them. But the priorities that the BHA outlines are people who are uninsured, underinsured, or whose income is below the 300% poverty level, women who are pregnant and using drugs by injection, people who use drugs by injection, women with dependent children, and that's on there too. And then people who are involuntary committed to treatment, and then those referrals from county child welfare departments. So SUD services, and Meg had mentioned this, we really wanted to just offer kind of a broad overview of the types of services that we fund as an MSO currently. We are in the process of working on our contracts with providers for SUD services, expanding to those 13 additional counties that are going to be part of our network starting July 1st. So we didn't want to get too specific just because those contracts are not yet signed. But generally speaking, the types of SUD services that we offer include circle programs. So those are co-occurring programs for people that need substance use treatment, residential substance use treatment, and mental health. They have mental health conditions as well, so they're treated in that circle program. Residential levels of care, so these are the ASAM levels of 3.1 and 3.5, and then Special Connections is a program specific for women that supports them and their children throughout their residential treatment. Outpatient services, medication-assisted treatment, and then mobile MAT. So we contracted with a couple of providers who have mobile units that travel throughout the region to provide MAT services and meet people in rural communities or smaller communities that don't have standalone facilities where people can receive MAT services. So those are wonderful programs, really intended to meet people where they're at, and they have schedules that they follow so that the community is well aware of where those mobile MAT units will be on what days, on what time, and they come to the same locations, generally speaking. Withdrawal management services, STIRT programming, including residential withdrawal management and respite. And those are programs that are specific to justice-involved individuals and supporting them throughout the continuum of services that they may need. Peer navigation, so we contract a number of providers that offer peer services for people who need support in whatever stage of their recovery journey they're in. Recovery support services, so again, those are those RCOs that provide activities and sort of alternative options for people who need a space to, in a community and a space around recovery. And then recovery living communities. So, those are those homes where, people can reside for the short term as they're stepping down from treatment, or if they need a supportive living community that is going to be supportive of their treatment. Okay, next slide. We also wanted to let you know the Colorado Crisis Services has rebranded their mental health line to the Colorado Mental Health 9. So this is that 988 number that many of you are probably aware of. It used to be an 844 number. So 988 is launching, and it already actually is in effect, but 988 is a number that you can call to get access to a crisis clinician. These are for anyone that's needing crisis services, and they are in a self-defined crisis. So it's really kind of up to them about what that crisis looks like. They can call, get support, and then if needed, get dispatch services to their location. So that's available for veterans, veteran-specific, people who speak Spanish, the LGBTQIA+ community, and so we wanted to provide that because it's gone through a bit of a rebrand. So you can click on that link there to be directed to their website, and we will make sure these slides get out to all of you. So that will show you what our BOSO region is starting July 1st. So we are the region in purple. Currently, we are the ASO and MSO for, if you follow along the line, basically just the western slope from north to south of Colorado. The BOSO for the regions in pink, yellow, and green is Signal Behavioral Health Network. They are a partner of ours. We work really closely with them and can help connect people, as they're calling for care coordination services to Signal, should they live outside of our region. And those are key contacts. So, if you have questions regarding our network services, availability, anything like that related to substance use disorders or programs for children, youth, and families, please feel free to reach out to me. Crisis services and provider contracting would be Chris Touche, and then any needs that you have, escalated needs, you can reach out to Nick Taylor, who presented to you all earlier. And that's all we have prepared. We'll make sure we open the floor to questions. If anybody has any.
Sure, we're gonna go ahead and open that up. Do we have anyone in the audience that has questions? Okay, we have one.
Can someone out of state, like New Mexico, can someone come out of state from like Rancho, New Mexico, come to any of these services for mental health care, substance abuse recovery, stuff like that?
Mayor Maureen, were you able to hear that question?
I wasn't. I heard something about New Mexico, but that's
Yeah, the question is, because we're a border town, they'd like to know if anyone from New Mexico would be eligible to come over to the Colorado side and receive services through either the Ray or the Basso.
So, for the Ray, only if they are, only if they have Colorado Medicaid as their health plan. Under the Basso, they actually have to live in the geography, so I hate saying no, it's a no. I will say that we're working with Southern Youth. They're developing a campus to provide residential services, outpatient services, recovery housing. It's a several years project, but you know, in the tribal community, that will be open to not just mountain tribal members, but all Native American people.
Okay, we have another one in the room.
There's one question.
Okay, I'm gonna try to be clear in my question here because I assume Michael's gonna have to repeat it. So, there's been funding cuts, particularly around like HRSA, different grants that employ peer support professionals. My question is if there's an existing pathway for, say, a nonprofit or a public health department who employs peer support professionals and doesn't currently bill through Medicaid to become part of the Recovery Support Service Provider Network. And is that a recommendation you have for organizations who've lost funding for their peer services? That was clear.
So let me try to repeat that.
No, I'm sorry.
It's a good question. So essentially, due to some of the grant funding cuts that we've seen across the state for peer recovery services, they're wondering if, can you repeat that first part?
If there's a pathway
If there's a pathway for them.
for nonprofits or like a health department
Okay.
who lost their funding to become a recovery support service provider. And
So-
that's a recommendation.
Okay, so they're looking at, is there an option or pathway for agencies that have lost that funding for peer recovery services? Is there a pathway for them to get certified in that again? And if so, what are your recommendations to do so?
So I can speak to this. I think probably like this lives in two different spaces. So the Recovery Support Service Organizations, the RSSOs, you can, you have to, the pathway is you need to get the designation from the Behavioral Health Administration, and then if you're not already enrolled with Medicaid, enroll in that provider type as an RSSO, and then contract with the RAE. So that is one pathway to try to plug that hole or, you know, overcome that, like what has been cut. So that's on the RAE side. Maureen, do you want to speak to it on the BASA side?
Yeah, I mean, I think I would love to connect with you. We're always looking for new providers. I will say for this fiscal year, you know, based on the funding that we have from the BHA, those funds for peer support services have been already allocated or earmarked for providers that are currently in our network or that were in the network of the counties that we will be serving. So unfortunately, it wouldn't be for this fiscal year, but I would always love to be able to expand and provide more localized support. So I can put my email address in the chat. And Michael, if you wouldn't mind passing that along to the individual that asked the question, you know, we always want to expand our providers. I think the thing that is really tough is that our budgets are limited to the funds that we get from the BHA. And so expanding can only happen when we have the funds to do so.
Sure. I actually have a question for you. So,
hey Michael, can I do a real quick follow-up to that one?
Sure.
If there is someone who's interested in becoming an RSSO, we have support to try to help you walk through the process. It does begin at the BHA because you have to have that designation. From providers that have gone through the process, it sounds like it's not very onerous on the BHA side, but you do have to have that BHA designation before you enroll that provider type on the Medicaid side. So just letting you know that we do have a team of people that will help you walk through the process and help and guide you where you need to go for like steps, the next steps. Go ahead, Michael.
So one of the questions I often get from mental health providers that are here in the region is they're very unfamiliar with how to enroll with Medicaid and how to enroll in Medicaid services to provide to the public. Does the BASO or the RAY provide guidance on that component, and who do they reach out to for that?
Yeah, absolutely. Absolutely, Michael, we do. And we really, I mean, so when Rockies started as a RAY 7 years ago, and we continue to do this, we have an open network for willing and qualified providers. So we can walk you through, thanks Maureen. So it's in the deck, but also she just put the connection point for our provider relations that can start the process with you. And if you walk in that door and they're like, okay, you still need this enrollment, we have people that can like work with you along the way from both the state top down, so the state and what happens next with the RAY, and then the same is with on the BASO side. So you can reach out directly to Maureen and we can work with you. Some of these provider types require designations under the BHA, so we can work with you and support you along that path too.
Any other questions in the room before I go to the questions we had online? Okay, so the first question online is, the service needs of the Southeast are very different than those of the Western Slope. What efforts will Rocky Mountain take to increase the number of services and access to services for this area?
So the question was specifically that there's a large or a vast difference between the Western Slope and the Southeast and Southern region of Colorado. And they're wondering what services or what, can you repeat that last part for me?
What efforts will Rocky Mountain take to increase the number of services and access to services for this area?
So the question is really, what effort is Rocky Mountain going to take to increase services within the region where it is relatively sparse, I will say?
Yeah, no, totally hear that. And I know that, I mean, I think that, you know, just because like things are rural and frontier doesn't mean they're all the same. Well, I think one of the things that we're learning right now is that maybe the network and those that have been in the current network of providers under the current ASO or the current RAY haven't been as open maybe. We had a provider event, January and February, we kind of did a traveling roadshow across that geography. And we had providers telling us that they had never had the opportunity to be in the network for Medicaid or other or under the ASO. And so we're already working with those providers to have them contracted with us, especially under the RAY. Like Maureen mentioned, we are doing our very best to maintain the network that was already established in the ASO and the MSO space in the new 13 counties that are part of our region. And as funds allow under the BASO, we will continue to expand that. The other thing that I did mention, and this information will be going out, every year we kind of do this like community stakeholder roadshow, and we will be traveling across with our partners at the Colorado Cross Disability Coalition to hear from the community, from providers, from people, so that you can tell us what you need and where the biggest gaps are. And I do know that there are a lot of gaps in services in your area. There are provider deserts, and that we need to work with you all to understand like what are the highest priorities and how we start tackling those together.
Sure. And just a quick follow-up, I think I have two more questions, but to that, Meg, I think one of the important things, especially for Los Animas County, is that as the largest geographical county within Colorado, it's extremely difficult for our folks that are in the same county, but it's a 2-hour drive sometimes to the seat here in Trinidad, who also don't have technology and the ability to connect virtual. So I would just like for the RAY and the BASO to keep in mind that those are definitely challenges to get those services implemented throughout our county. The next question.
Thank you, Michael. I would just like to say on that note, I mean, we have, that is something that we have, I would say definitely like the very southwest and the very northwest of the state that we have been working on over the past 7 years. And one of the things that we've found successful, and this is both in the SCD space, but in the broader, behavioral health space, including mental health, is how we use mobile clinics and mobile services. We expanded mobile diagnostic that basically travels all over the Western Slope to get to people. Because especially we know that like sometimes like people don't have the technology or broadband to connect, even if something's offered virtual, and definitely like transportation is a barrier, absolutely. And so we want to get the opportunity to have like kind of like that mobilization of services is something that we're always looking to.
Awesome, thank you. Our next question is, how can folks working with people impacted by SUD or SUD connect with the care coordinators?
So for RAE care coordination, we have a direct RAE care coordination line and email address we can use. Under the BOSO, as Maureen mentioned, there are certain care coordination services that are specific to current programs under the MSO and the ASO. But for moving into July 1st, there will be a dedicated care coordination phone number and a dedicated care coordination email that you can access services through, either directly through the BHA. They'll have one website, and we'll be sharing that information. We have not published the phone. We have not publicized the phone number yet because it doesn't go live until 7/1, and we didn't want people calling and just getting a voicemail. Because that part of our contract and our staffing and everything doesn't go live till 7/1, but we can definitely share that with you. And I'll put the current RAE information in the chat for connecting for RAE care coordination. Thanks, Maureen.
And then the final question we have from online is, how can people join the advisory council, specifically the BOSO?
Yep. So that is a very good question. So under Behavioral Health Administration statute, and for the BOSOs, there are specific seats that are part of our regional advisory councils under the BOSOs, our BOSO regional advisory councils. Some of those appointments are made by the BHA, and some of them are recommended by us but approved by the BHA. So that is something in process right now. If anyone is interested in being part of that regional council, please let me know and I will get you in the pipeline with the BHA. For our member advisory councils, those are kind of the RAE, but we spend so much time in our member advisory councils talking about behavioral health that we're going to really make them multidisciplinary. So it's not just Medicaid. We've talked to our Medicaid members that are part of our member advisory councils, and they really welcome other voices in the rooms around the BOSO. So again, you can send your interest directly to me. I'm happy to connect with you, and then connect you either with the BHA, who will be making the specific appointments for the statutory requirements, and then also the information about where our councils are.
I know we asked if there were any additional questions online. Do we have any additional in the room?
I think everybody's ready for lunch.
Well, Maureen, thank you guys so much for attending and presenting today. We really appreciate all of the information and we look forward to collaborating with you.
Awesome. Thank you all. Have a
Thank you so much. Have a great day.
So for folks online and those in the room, can you hear me? Is that better? Okay. For the folks in the room, lunch will commence now. We will come back at 1 o'clock on the dot for our next panel discussion. Also, as we navigate through the 2 days, if you have additional questions that you come up with after and you'd like us to direct those to any of the presenters, there are sticky notes on your tables. Please feel free to put that question and put the presenter's name. And then, Ms. Marcy, did we put over here in the back left corner, there's a paper on the wall that you can stick those sticky notes to, and then we'll be sure to get that information to them. For folks online, you can enter those questions into the chat because it is recorded. We'll make sure we get those questions to them as well. Okay.
Michael, as they keep falling off, if people want to give me their sticky notes, I'll make sure we collect them all.
Okay. So again, we're at lunch now, break. So please enjoy yourselves. And we'll see you back at 1 o'clock.
So what I need